Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast two dear friends and colleagues, Dr. Alejandra Martinez and Martina Angeles. We're going to talk this podcast on the August lead article. It is titled Outcomes of Minimal Residual Disease at Upfront Debulking Surgery compared with complete cytoreduction after neoadjuvant chemotherapy. Alejandra, Martina, thank you so much for joining and spending this time with us discussing this important article.
Thank you. Thank you very much for this kind invitation.
Thank you very much, Pedro, for the opportunity.
Of course. Well, and I should also mention congratulations to all of the co-authors as well for their work, and thank you again to both of you for sending it to our journal. So we have lots of questions for this podcast, and I'll begin with you, Martina. So can we start by discussing what's the main question at hand here in this study? Are we trying to find out if leaving some minimal residual disease at upfront surgery is equivalent to no residual disease at interval?
Yes, exactly. What we really wanted to understand is whether performing primary debulking surgery with minimal residual disease, specifically lesions under 2.5 millimeters, leads to similar survival outcomes compared to achieving complete cytoreduction after neoadjuvant chemotherapy. And then we also aim to compare the surgical complexity and postoperative complications between these two approaches, between PDS with CC1 and EDS with CC0.
So now, I'm going to follow this up with my next question. You know, certainly in the study, you looked at time span between 2008 and 2015. What do you think might have changed in terms of the management of these patients that could have impacted your outcomes?
Yes, the study covers patients treated between 2008 and 2015, as you said, which gave us a robust follow-up period of over 68 months, and that's definitively a strength of our study. But as you mentioned, the landscape in advanced ovarian cancer has changed significantly since then. The major shift has been in the introduction of PARP inhibitors as maintenance therapy. That said, trials involving PARP inhibitors still suggest a survival advantage for PDS over EDS, so we believe that our findings would likely hold. But another important evolution is in the surgical technique, as more radical procedures are now performed to achieve no gross residual disease after surgery. However, CC1 typically refers to miliary disease in the bowel, which is particularly difficult to remove during surgery. And we believe that the prognosis for this group of patients wouldn't be substantially different today.
Great. So I'll turn over to Alejandra now. And Alejandra, I wanted to ask you, you obviously, again, great achievement to have multiple centers contributing data. This was a multi-center study of 4 centers in Spain and France. Why did you pick those 4 centers?
So we performed the study in 2 French and 2 Spanish referral centers for ovarian cancer, and all the institutions are ESGO-accredited centers. And all of us are aligned on the same surgical strategy for ovarian cancer. We all perform patient selection with laparoscopic assessment, and we all perform primary cytoreductive surgery when possible. And of course, we all perform radical procedures.
So now, Martina, I wanted to ask you, and you've already been referencing it, to the distinctions between CC0, CC1, CC2, CC3. Where did you get these definitions from, and why is it important to have this distinction for this study?
Okay, yes. So we use the completeness of cytoreduction score, which is commonly known as the CC score, and it was originally described by Sugar-Baker in 1994. Initially, it was used in the context of peritoneal malignancies and other digestive tumors with carcinomatosis, such as gastric or colorectal cancer, which were treated with cytoreductive surgery. We believe that this classification is more precise than the traditional cutoff of less than or more than 1 centimeter. For instance, a review by Chiva et al. In 2016 showed that patients with residual tumor between 1 and 5 millimeters had a better survival than those with tumor between 5 millimeters and 1 centimeter. And this highlights the need of a finer stratification of the patients with residual disease. In our institutions, when a patient ends up with CC1 after PDS, it's usually due to tiny bowel implants that are, as I said previously, extremely difficult to resect during surgery. And if we anticipate more extensive residual disease, more than 1 centimeter, we opt for neoadjuvant chemotherapy. So I believe these were the reasons to use the CC score.
Great. So that's a great segue to the next question that I'll turn to Alejandra for this. This one comes from one of our fellows, Rosano Marina. She's from the European Institute of Oncology in Milan. And she's asking, what was the rationale for selecting 2.5 millimeter cutoff for minimal residual disease rather than the more commonly used thresholds of 1 centimeter or 0?
Yes, thank you for the question. So as Martina has just explained, the size of residual disease has a prognostic value, and we know that tumors under 2.5 millimeters are associated with better survival than those under 1 centimeter. So in our institutions, we systematically use the PCI score to assess both the extension of the disease and the CC score, the completeness of cytoreduction at the end of surgery. So selecting 2.5 millimeters aligns with the CC1 score from the PCI and allows us to select this group of patients who have minimal residual disease, yet measurable disease. And when we have larger residual disease after surgery, we usually go for neoadjuvant chemotherapy.
Great. So now, Martina, let's get on to the results of the study. As we mentioned before, 4 centers in France and Spain, 549 patients. What are some of the highlights?
Okay, so what we found is that patients who underwent primary double-click surgery with minimal residual disease had similar survival outcomes, both in terms of DFS and OS, compared to those who had complete cytoreduction after neoadjuvant chemotherapy. Interestingly, tumor burden was higher in the PDS-CC1 group, with a PCI above 10 observed in 82% of patients, compared to just 40% in the EDS-CC0 group. We also noted a trend toward lower surgical complexity and fewer postoperative complications in the EDS group, although these differences weren't statistically significant. Indeed, the proportion of patients with a Leti score above 8 was 61% in PDS-CC1 group and 41% in the EDS-CC0 group. And the rate of major postoperative complications was 28% in PDS-CC1 group and 20% in EDS-CC0 group. So
now let's start talking about some of these results. And Alejandra, I'll turn to you on this one. I noticed that 70% of patients receive neoadjuvant chemotherapy, even in centers in France, in Spain. This is actually very consistent with what we're seeing in the United States. What do you think is driving this overwhelming trend towards neoadjuvant chemotherapy?
Well, you're right. I think there's a global shift towards neoadjuvant chemotherapy, probably driven by the results of several trials showing non-inferior results when patients undergo neoadjuvant chemotherapy, even if these trials have been criticized, especially regarding the surgical results. But also for French institutions, for both participating centers in this study, the reality is that these are referral centers. So many times we receive patients that have already started chemotherapy, which means that the initial assessment has been performed outside our institution. So maybe this can partially explain the high rate of neoadjuvant chemotherapy in our study.
Yeah, completely agree. And one of the other things also that we're seeing in our institution is that not only are patients coming in after starting neoadjuvant chemotherapy, often they're coming in after having completed all 6 cycles of chemotherapy. So interesting observations there. So now, Martina, I'll turn to you. This question is from Helena Obermeyer in Sydney, Australia. And she's asking, was there a standardized approach regarding surgical technique across centers in your study, such as minimally invasive versus open debulking? Do you think variations in surgical technique could have influenced rates of complete cytoreduction, surgical complexity, or complication rates?
Yes, thank you. Thank you very much, Elena, for these questions. Indeed, all surgeries in our study were performed via laparotomy, via the open approach, which was the standard approach during the study period, 2008-2015. And indeed, it remains the gold standard today. It's true that more recently there is growing evidence supporting minimally invasive surgery in selected IDES patients with good response to chemotherapy, and this is gradually being implemented in clinical practice, particularly in those patients with complete response to neoadjuvant chemotherapy. But during our study period, the surgical approach was consistent across centers. So answering to your question, we don't believe that variations in surgical technique had a significant impact on cytoreduction rates, surgical complexity, or complication rates.
Excellent. Alejandra, this question comes from Frederic Stroich at Heidelberg University Hospital. And she's asking, complete cytoreduction rates of 90% and 87% for primary and interval respectively were reported in your study. In comparison, the TRUST trial achieved optimal cytoreduction of only 62% in primary and 72% in interval. How do you interpret these comparatively higher rates in your study? In your opinion, what is the most appropriate and standardized way to report residual disease after cytoreduction?
Okay, so thank you. Concerning the first question, I think it needs some clarification, because in our study, we only included patients who achieved CC0 or CC1 results, so patients who had less than 2.5 millimeters, and patients with CC2 residual disease were excluded. So the 90% in the PDS and 87% in the IDS group are not the rates of complete cytoreduction, but the proportion of patients included in the study with CC0, CC1. If we had included patients with CC2 or higher, so with greater residual disease, the rates of complete cytoreduction would have been lower. And the second question was on the best way to report residual disease. So I believe the CC score, as we previously discussed, is the most appropriate method to describe residual disease. And I think it's also very important to detail in the operative report the size, but also the location, the anatomical location of any residual lesions.
Excellent. So turn to Martina now. This question comes from Sofia Bigardi from Padova University in Italy. She says, given that tumor biology such as BRCA mutation or HRD status can significantly influence response to chemotherapy and timing of recurrence, could the absence of molecular stratification in your study have masked meaningful differences in progression-free survival between the primary CC1 and the interval CC0? Do you think incorporating this information at the time of exploratory laparoscopy could improve decision-making on surgical timing?
Yes, absolutely. This is a very interesting question. HRD status could definitively have impacted survival outcomes. Patients in the EDS CC0 group are more likely to harbor BRCA mutations or be HRD positive, which makes them more responsive to chemotherapy, and that could partially explain their better outcomes. And having this molecular information available at the time of diagnostic laparoscopy would be ideal. It would certainly help us to tailor our decisions, as probably patients with BRCA mutant or HRD tumors and high tumor burden might potentially benefit from neoadjuvant chemotherapy and EDS. But in practice, this data is rarely available before starting the treatment. And so surgical decision still relies heavily on imaging, on tumor distribution found during laparoscopy, and on clinical assessment.
Yeah.
Hmm.
So, Alejandra, you want to
Maybe
make a comment?
I'd like to just make a small comment. I
Uh-huh.
completely agree with Martina, but I think that concerning surgical decision making right now, we have insufficient data to limit the surgical effort or to modify the surgical strategy depending on the HRD status. And for example, all the PARP inhibitors trials show the best survival for patients who undergo upfront surgery, including those with HRD, and also the best benefit for maintenance treatment with PARP in that subgroup of patients. And I think that we should wait maybe the subgroup analysis on the genetic status in the TRUST study will have to answer this question.
Great. No, thank you for adding that. So, Alejandra, I'll stay with you. This question comes from Natalia Tejera, Hospital Clínic of Barcelona. And she asks, in the paper you mentioned that patients with poor initial performance status were more likely to be selected for neoadjuvant chemotherapy. Given that ovarian cancer is frequently diagnosed in elderly and frail individuals, how exactly was frailty assessed in your study? Was a standardized tool or score used, or was the decision based on clinical judgment alone?
Mm-hmm. This is a very important question. Thank you very much, Natalia. So initial screening for frailty probably depended a bit on the participating institutions, as we did not have any restrictive inclusion criteria for our study. In our center, and I believe in the other French center, we perform an initial screening based on the G8 geriatric screening tool, which is a very simple scale which has 8 questions like food intake or mobility or weight loss. And all patients aged of 70 or more undergo this questionnaire, this screening with this tool. And when they have a low score under 14, then they undergo a full geriatric assessment. This is the same situation for all patients over 85. We usually perform a full geriatric assessment prior to any treatment, prior to surgery and prior to chemotherapy. And of course, the result from the geriatric assessment is considered with the rest of the criteria in the tumor board.
Excellent.
To either go for chemotherapy or for upfront cytoreduction. Okay.
Martina, this other question comes from Frederic in Heidelberg University Hospital again. She says, you used the PCI to describe the extent of peritoneal carcinomatosis. A PCI greater than 10 was significantly more frequent in the primary CC1 group compared to the interval CC0 group, 82% versus 40%. Was this score documented prospectively in clinical records, or did you actually have to go back and calculate it?
Yes, it's very, very interesting question as well. No, PCI was systematically assessed during surgery and documented in the operative report at all participating centers. For the purposes of the study, we reviewed these reports retrospectively to extract the data, but the score itself was prospectively recorded during the surgical procedures.
Okay. And then, Alejandra, I'll turn to you again, a question from Natalia Tejeda. In your study, patients with PCI less than 10 at the time of surgery had better outcomes. For patients in the neoadjuvant chemotherapy group, do you have data on PCI at the time of initial diagnosis? Do you believe initial PCI correlates with survival outcomes independently of surgical PCI?
Thank you, Natalia. I like very much this question. So the first thing is that in our study, unfortunately, we did not have the PCI at the initial diagnosis, so only at the time of surgery, PDS or IDS. So concerning low tumor load, yes, I believe that tumor burden, well, measured by the PCA in our study, is directly correlated with survival. And there are some studies to support this. We have the Scottish trial, the SCOTROC trial, showing the correlation between the tumor load and survival. And we also have our own data that has been published in Gynecologic Oncology and in the Journal of Gynecologic Oncology like 2-3 years ago. Showing the prognostic effect of tumor burden in patients undergoing complete cytoreduction. And there's also a recent paper published in the International Journal by our colleagues in Paris, by Sébastien Gouy from Gustave Roussy, showing a linear correlation between the PCI and survival, both for PFS and OS, and both for at the time of primary or interval debulking surgery. So I think that the key question is to know whether patients with low tumor bulk benefit more from a not from procedure or if they have the same survival when they undergo neoadjuvant chemotherapy. And I think we do not have the answer to this question, but we know that the subgroup analysis from the EORTC trial, this was the subgroup of patients who gained most from upfront cytoreduction. So this is the reason why we plan to develop a new trial from the GYNECO group, which is the LOTUS trial, aiming to demonstrate the benefit of primary over interval debulking surgery in well-selected patients, which are patients with low tumor bulk selection criteria, using also criteria to exclude frailty and ensure complete surgery with a low complication risk. And I think this is the best strategy to select patients who would benefit most from an upfront surgery.
That sounds great. Looking forward to the results of that. Turning to Martina now, Filippo Capomacchia from Cardiolo Cancer Institute in Candiolo, Italy. He says, in your study, patients were enrolled a period preceding the adoption of PARP inhibitors as maintenance therapy for advanced ovarian cancer. How do you think that adoption of PARP inhibitor maintenance therapy may influence these results?
Yes, very, very interesting question as well. If patients in our cohort have received maintenance therapy with PARP inhibitors, we believe that overall outcomes would have been quite similar with comparable prognosis between both groups. That said, we also might have seen an additional survival benefit in the EDS-CC0 group, given that these patients tend to have higher chemosensitivity and are more likely to carry BRCA mutations or show HRD positivity, and they would have been treated with PARP inhibitors, no? So yes, it's possible that PARP inhibitors would have increased the survival advantage for that EDS-CC0 group.
Excellent. And Martina, I'll stay with you. Luisa Prope from University Hospital in Münster. She's asking, you reported on non-significant trends towards lower surgical complexity in the interval debulking group, which may affect patients' quality of life. Given that survival was similar in both of your groups, don't you think we should focus more on patients' quality of life and long-term recovery?
Yes, definitely, Luisa. Since survival outcomes were comparable between both groups, it makes sense that to shift our focus towards quality of life and long-term recovery. Although statistically not significant, we saw a trend toward lower surgical complexity and fewer major complications in the EDS group. The lack of significance could be due to the limited sample size, but this difference still matters, I believe, because surgical morbidity, risk of complications, and the overall impact on quality of life should all be weighted carefully when choosing the treatment strategy. And then, according to our data, if we anticipate CC1 after PDS, EDS may be a better option.
Very well. Alejandra, we're going back to the TRUST trial. This question comes from Helena Overmeyer, and she's asking, recent presentation of the TRUST trial has reignited a lot of discussion about the role of upfront surgery versus neoadjuvant chemotherapy and interval surgery. How do you interpret your findings of comparable survival between primary with minimal residual and interval with complete cytoreduction in the context of the TRUST trial?
Thank you, Elena, for this excellent question once again. So yes, so our study showed similar survival between CC1 operated at PDS and CC0, so complete operated at IDS. But patients who had minimal residual after primary cytoreduction had higher tumor bulk, higher surgical complexity, so more radical surgeries, and also a higher complication rate. So I think that after the TRUST trial results, these patients should undergo neoadjuvant chemotherapy. And as I think there is probably no survival gain after PDS for them, but higher associated morbidity.
Very well. We'll stay with you, Alejandra. Sofia Bigardi is asking, do you know whether the chemotherapy response score was evaluated in the interval surgery group? And if it wasn't, how does that affect our ability to really understand how chemosensitive these tumors are and how much that might have influenced survival outcomes in your study?
So thank you, Pedro, and thank you, Sofia, because yes, the CRS score was assessed in this cohort of patients, and this paper was published in the International Journal, and we did a podcast on this question, so you can listen to it and to the Journal Club. And in our results showed that persistent histological disease, so patients who have CRS 1 or 2, was significantly associated with higher PCI and also residual disease, which is logical. And we also saw that CRS was the most important prognostic factor in multivariate analysis. We observed complete or nearly complete, so CRS3 responses in around 24-25% of patients. And those patients had like a doubled overall survival, median overall survival. So like 105 months compared to 45-46 months for patients with CRS 1-2.
Excellent. So Martina, last question for you comes from Filippo Capomacchia. And he says, in your study, the primary surgery CC1 cohort included only 18 patients. How might this small sample size have impacted power of analysis?
Yes, I completely agree. That's an important limitation of our study, and we are very aware of it. The small sample size in the PDS-CC1 group definitively reduces the statistical power and means that our conclusions should be interpreted with caution. While the trends we observe are informative and potentially relevant, larger cohorts are needed to validate our findings with more robust evidence, of course.
Great. Last question for you, Alejandra. I always take advantage of asking, what do the authors do at their institution? So if you have a patient who is in her 60s, very good performance status, comes in with what appears to be by imaging and serum CA125 to be consistent with advanced ovarian cancer. What's your algorithm as you're looking at this patient in your clinic to go for surgery versus neoadjuvant chemotherapy?
Thank you for the question. I'll do a very quick summary. So basically, we look at three things. The first one is frailty, the patient general condition, and see if she can tolerate or not cytoreductive surgery. The second one is the extent and the distribution of the disease. So in this patient who has 60 years, so good general status, and the peritoneal carcinomatosis on imaging, we would go we would perform laparoscopic assessment first. And in my institution, we perform a two-step procedure, which means that we perform laparoscopic assessment with biopsies, and then we plan the cytoreductive surgery if we go to upfront surgery, like 1 week or 10 days after laparoscopy. And finally, and of course, during the laparoscopic assessment, we balance the surgical decision depending on the possibility, of course, of having a complete cytoreduction, but also the extension of the surgery, the radicality, and the risk of potential complications. And the third thing that we also consider, of course, is tumor biology, and in particular for tumors who have low chemosensitivity, for example, for low grade, well, then we do very big or larger surgical effort. And we nearly always go for upfront procedures.
Excellent. Well, and thank you so much to both of you for taking the time to discuss this with us, with our audience. Really always enjoy speaking with you so much. Thank you again. Alejandra, welcome back to the podcast. And then, of course, Martina, always a member of the IJGC family. So really wonderful to speak to both of you. Congratulations to all the authors. And we're really looking forward to the journal club on this particular topic. So once again, thank you for your time and accepting the invitation. And I should say, thank you for the contributions you both are making to gynecologic oncology.
Thank you very much, Pedro.
Thank you, Pedro. It has been a pleasure.